It's time now for the award-winning #1 local talk show in Northeast Pennsylvania, The Sam Lesante Show. Now here's your host, Sam Lesante.
So folks, I got good news and bad news for you. Let me give you the bad news first. The bad news is that 25,000 women are diagnosed with ovarian cancer each year. Unfortunately, 15,000 of those 25,000 die. However, the good news is we got great doctors these days, particularly in the Lehigh Valley Health Network, where we could do screenings, we could look at prevention, we could look at recommendations, and it's so great to know that we have the availability of the doctors that we have today, and we want to thank Lehigh Valley Health Network for providing those doctors. And we have those two of the great doctors on my show today. No stranger to the show, Dr. Michael Evans, who is from the Hematology Oncology, the Hazleton and Mountaintop area, and Dr. Richard Boulay, who is a gynecologist oncologist. Now, I'm going to tell you, folks, you can see why that's important. Gynecologist and oncologist. First, doctors, thanks for coming on the show.
Thanks for having me. Thanks for having us.
It's interesting, Mike, when I was in your office, we were talking about ovarian cancer, okay? And it's funny that Tammy calls and says, you know, we want to have a show on that, which is educational. So as you said, women are diagnosed with breast cancer, how many, 250,000?
Roughly, yeah.
And how many are say, I mean, how many, the percentage
the mortality annually, I think, is about 40 to 45,000 for breast cancer. So that's about 20% of the annual incidence.
So, as Dr. Boulay says, the screening and the MRIs. But let's for those people who don't know who this guy is great, folks, Dr. Evans. Okay, tell me a little bit about yourself. I have to tell you you're great because you're taking care of me. Okay.
Well, thank you.
I'm not dying, guys. I'm not dying. If I die, I'll never speak to him again, I'll tell you. Mike, tell me a little bit about yourself.
I am a hematologist medical oncologist, so that means my background is in internal medicine. So trained in internal medicine, which prepares you to either be a generalist or to go on to specialize. And so after internal medicine, I specialized in hematology and medical oncology, which is really much more the chemotherapy side of cancer rather than the surgical side of cancer or radiation side of cancer, and then hematology is blood cancers as well as other blood disorders.
Okay, so staying on the subject of ovarian cancer, okay, the incidence what does it look like currently?
So currently it is a cancer with a high mortality rate. So in comparison to breast, it's more like 60 or 70% of the annual incidence is reflected in the annual mortality for ovarian cancer, which is a lot higher than we'd like it to be. And I think that actually makes it about the 5th leading cause of cancer deaths in women, despite the fact that it's not an extremely common cancer in women. So it means that there's a lot of room for improvement. And the unfortunate side of things as they are now is that most women, as Dr. Boulay mentioned, are diagnosed with advanced stage disease, stage 3 or 4 disease. And part of that is because despite efforts to identify effective screening, there has not been a very effective method of screening identified yet.
Okay, so I mentioned that we come a long way, okay, with the doctors and the screenings, et cetera, we have today. So who would be most at risk for developing ovarian cancer?
So the risk factors generally come down to genetics first and foremost. So people with a first-degree family member who have had ovarian cancer are at a 3 to 4 times higher risk than the general population who doesn't have that family member.
So what do they do?
Basically, well, there's people who have a first-degree relative. There's also people who have known familial cancer syndromes. And for those people, depending on which syndrome you have, the rates can be much higher. So it can be as high as 40% lifetime risk of ovarian cancer. So in those, there's differences there. In people with the cancer syndromes, a lot of people have heard about the BRCA mutation because of breast cancer and Angelina Jolie and how she's brought that into the public spotlight. The options there include surgery, basically, as they do with breast cancer, mastectomy. You could do similar things with surgical prevention of ovarian cancer with oophorectomy.
Okay, now, if your mother or your sister or relative had ovarian cancer, all right, and you're at risk. Okay, so they come for a screening, or what should they do?
That if it's an individual who has not been diagnosed with anything but has a risk, my advice would generally be to have them go to their family member, hopefully if they're still doing well, to see what was identified as far as a family syndrome for that individual. Otherwise, maybe you have something more to add to this. Just vigilance, I think, would be important. If most women with ovarian cancer present with abdominal fullness or bloating or changes in their appetite, any symptoms like that, I would be very vigilant and bring them right to medical attention.
So, Dr. Boulay, I'm going to get to you. The screening recommendations for ovarian cancer, okay, in both high and low risk groups, okay. At what age do these recommendations begin at? So now we have a person who has had a history in their family of ovarian cancer. Okay, so what should they do?
So as you described, the recommendations for screening vary according to high risk and low risk. So high risk are those people, as Dr. Evans was describing, that have a genetic abnormality within their family or within themselves that predisposes them to getting ovarian cancer. Remember, ovarian cancer is really rare. 1.5% of people will get it over their lifetime. And when we're talking breast cancer, it's 10 times higher than that. So this is a disease that's sometimes like finding a needle in a haystack. So if we can make the haystack smaller, yes, and know if you are at risk, yes, then that makes it easier. So as Dr. Evans was saying, if you have a family member with ovarian cancer in your family, you should see a genetics counselor and get screened with blood work to see if you possess that same gene that may have caused your family member's cancer. Now, even better is to get the first person who had the cancer to get them screened for potential genetic mutations. So that's the first thing. The second thing is to see your OBGYN provider regularly for annual exams and be vigilant, as Dr. Evans said, toward some of the earlier symptoms of ovarian cancer. When we think of ovarian cancer, we think of a belly full of fluid and bowel disruptions and feeling like you can't eat a full meal. Those are some of the later symptoms. Some of the earlier ones, if we can find them, and they're really, we have a saying that ovarian cancer whispers, so listen. Some of the whispers that people notice are sense of bladder infections without an infection, a sense of bladder urgency, you have to pee all the time, a sense of fullness in the pelvis or minor bowel changes, and some discomfort in the pelvis. And these are things that everybody gets every day. But if you get a persistence of this that's lasting at least 2 to 4 weeks, then you should see your OBGYN provider to at least do an exam and potentially an ultrasound.
Is there an age difference? I mean, does it happen certain ages, or?
That's one of the high risk, low risk things too. Most ovarian cancer, the average age of diagnosis is around 60 or 61. But in patients who have the genetic risk, it can be as low as the 20s.
Yes.
So when you do your annual screens for OBGYN, they're screening for this anyway, and those generally start at 21. So you're getting that. If you have one of the higher risk categories, then you should probably be screened with blood work called a CA-125, as well as an ultrasound annually.
Yeah, I mean, I've known, my wife's a registered nurse, but she has known a number of people who have young women, 20s, 25, 30 some, that have ovarian cancer. So you just wonder what do they do, to prevent this? So if you have a history in the family of ovarian cancer, if you're 21 or whatever, your suggestion is what?
Start with a genetics counselor. So your OBGYN provider or family doc can provide you with a consultation to at least a master's trained genetics counselor who can go through what we call a pedigree. They can go through your whole family. It takes a whole hour to figure out who had what when. And then from that, they can assess, using computer modeling, your potential risk for these various gene disorders. And then it's a simple blood test from that. that to get it. Short of that, if there are none in your area, then the rule of thumb for all cancers, not ovarian cancer alone, is that if there is someone that's diagnosed with your family at a very young age, you should start screening for that disease at least 10 years earlier than that person had it. So if your mom had an ovarian cancer at age 40, then you should start, and we can't find a genetics abnormality, it's very reasonable to start screening at age 30 with the ultrasounds and the blood tests.
Who would be considered, Dr. Evans, a low risk?
Low risk would be, obviously eliminating all the high-risk features relating to family history. There's also a so-called hormonal risk to developing ovarian cancer. So people are at lower risk if they have had more pregnancies. People are at lower risk if they breastfeed. I believe people are at lower risk if they're on hormonal contraception. So there's things like that lower risk.
Is there any telltale signs that women have? I mean, you mentioned some of the possibilities, but sometimes, like you said, well, maybe some women take it for granted. First of all, I would never want to be a woman today. Never in a million years. God bless them. They're strong. I mean, I'm a baby, and I think men can't compare to women. But you wonder, like, I go for yearly tests, the blood work, the whole bit, so Benyo will say this or whatever, and then, so you try to prevent whatever you can to stay on top of things, okay? Is there something women can do? We know now if they have a history, they should definitely get to the gynecologist, and correct?
Oh, definitely,
yeah.
as we were talking about, yeah.
So, but just an average, like you're in 50s or you're 60s right now, some women feel they don't have to go to gynecologist when they get older, which I think is wrong, isn't it?
Yeah, the current recommendation is if your ovaries are there. Some people have gone through hysterectomies and have surprisingly, you can still get an ovarian-like cancer even after ovaries and tubes are removed. But for those folks, annual exams, and we try to do medicine by data that we've developed, data sets that can point to evidence that really shows that these things work. But we don't have a lot of good evidence that shows that even exams work. But it's cheap and it's there for us, and it's if you're going to your OB/GYN, they screen you for it, probably without you even knowing it. And that screen is the physical exam. And I agree, many women when they're done with childbearing, especially after menopause, are kind of happy to be done with a gynecologist. But as we said, ovarian cancer peaks in its incidence, peaks in its diagnosis around early 60s. So that's the time when you really want to be screened for this.
In your experience throughout the years, Dr. Boulay, what age groups have you found? What are predominant age groups that have ovarian cancer?
So when we talk about ovarian cancer, we're talking about a number of different types of cancers. When we hear ovarian cancer, the thing like Gilda Radner's cancer and those things, we're thinking of what we call the epithelial cancers. And as I said, those are predominantly later in life. There are a number of juvenile ovarian cancers as well that children can get, as well as young adults, that are also challenging to screen for, because those are the people that you don't expect are going to get a cancer. So yeah, you have to be vigilant throughout your entire life, because different types of ovarian cancer will peak in their numbers at different times during your life.
So what you're saying, although you say it's sometimes very difficult to determine whether a person has ovarian cancer, there are that whisper you said. Mm-hmm. You still could hear a whisper, mm-hmm. Okay? And so if women, first of all, if you have a history, it's a no-brainer. Just get to the gynecologist and get examined, correct?
Correct.
And so the risk factor of any women, so first of all, women should be going once a year to get examined anyway, like everyone should. So when you're looking at the individual women in this age group, so how many, in your experience, and I know there's different ages, but a majority, a percentage, what age were they?
After menopause, after 50.
After 50.
Mm-hmm.
Folks, I'm talking to Dr. Boulay. Dr. Boulay is from the Allentown area here in Lehigh Valley of Allentown. Dr. Evans is here in Hazleton, also Mountaintop. Phone numbers, just call for information for Dr. Evans is 5014-LVH. And for Dr. Boulay, 570-401-CARE, C-E-R-E. We'll take a break. We'll come back right after this. Thanks for staying with us, folks. I'm Sam Lesante. You're watching the Sam Lesante Show. Remember, 24/7, all of our local programs on ssptv.com. My email is sam@ssptv.com. And once again, the health shows, folks, we're giving you great information. Today, the topics: ovarian cancer, prevention, screening, recommendations, and treatment. The doctors on the show today, Dr. Richard Boulay, who is a gynecologist oncologist. We'll tell you why that's so very important. Excuse me. Dr. Michael Evans, hematology oncologist up in Hazleton, also Mountaintop. I want to make a correction on the phone number for Dr. Boulay. It's 610-402-CARE. That's 610-402-CARE. Okay, so now, Dr. Boulay, the CA-125 blood screening, what does it mean?
So CA-125 is a simple blood test that is designed initially to identify ovarian cancer. It is good and bad. It's the best one we got that's available. It is unfortunately geared toward a specific subset of ovarian cancer, so it will only pick up about 80% of them. And of those cases that are early, stage 1s, it's going to still miss half of them. So it's got a lot of room for improvement, as we discussed. But it does have some utility. Before we talked about screening for ovarian cancer, and we mentioned exam, in addition to that, pelvic ultrasounds have been utilized over the past 20 years. And as they've been getting better, we've been finding more of them and identifying more normals that we don't have to follow up on. The CA-125 is an adjunct to that, and in some recent studies has shown that over time, it may be a better predictor for ovarian cancer than the ultrasounds. Ultrasounds offer a snapshot in time. In the ovary, especially for women who are before the menopause, the ovary changes with their monthly cycle. So identifying normal changes and cancerous changes can be quite tricky. CA-125 is generally going to stay on a plateau for most of someone's life, but then start to rise when a cancer comes in. So a one-shot CA-125 blood work may not be particularly helpful, but again, over time, it may prove to be a better identifier of early cancers than ultrasound has been.
So if there's a history of ovarian cancer, this is where a person would get this particular blood
If there's
test?
a history, you should use both.
Yeah.
You should definitely use both. If there is a low risk, so patients without family history, oftentimes we'll use the CA-125 as a tiebreaker, say. So we have an ultrasound that's suspicious but not diagnosis. I may use a one-shot CA-125 at that time to help to
Okay,
define
so at the
when
beginning of
it's
the show, I said I got good news and bad news. The bad news was that 25,000 people, women, are diagnosed with ovarian cancer. Unfortunately, mortality rate is 15,000 of those. Okay, so the good news is the fact that you want to get it detected as soon as possible. Okay, so now we get the bad news. You know, you're diagnosed with ovarian cancer. Okay, hopefully it's not in the fourth stage or whatever. Okay, so now it's not a death sentence. Okay, thank God, because we have what we have today. So what happens now? Let's say cancer is detected. Mike, you want to start off with that?
So what happens next after cancer is detected?
Yeah.
You know, in my mind, I'm not usually at the front lines of this, but the cases that I have seen, you know, somebody might be in the hospital because they're not feeling well. They're having a lot of the symptoms you were describing with the bloating. And then some imaging identifies, you know, an abnormality that's pointing to the ovary. In a situation like that, you know, in our area, we don't have a GYN oncologist. So usually, if it looks like a tumor, they call a medical oncologist, and they'll probably call a gynecologist. And you know, at least the relationship that I have with the gynecologist in the network, the next step usually is to move a patient like that down to Allentown so they can see someone like Dr. Boulay or his colleagues.
In the beginning of the show, I also said why it's important that we're talking about a gynecologist, oncologist, okay? So why is that critical that we go to a gynecologist/oncologist?
So we talked a little bit about evidence-based practice before then, and Simply in the evidence that we look at, GYN oncologists do a far better job surgically at attaining the goals of ovarian cancer treatment. So as Dr. Evans said, when patients are diagnosed, CAT scan and that's so forth, we understand that an ovarian cancer treatment is a multimodal treatment and involves generally surgery and chemotherapy. The timing of which surgery at the beginning, during the middle, at the end, the chemotherapy used and how it's given, whether we give it directly in the belly where the majority of the disease is or whether we give it IV, are all questions that need to be answered kind of right up front. So specialists who specialize in ovarian cancer alone, such as GYN oncologists like myself, are best trained to answer those questions. Not a shameless plug for us in general, it just shows what our training is. So different to Dr. Evans' training, I started on an OBGYN pathway. So I got very familiar with operating in the pelvis. I got very familiar with pelvic examinations. And after you do 1,000, you can find the little teeny changes that may be real subtle to pick up unless you've done a lot before. So in addition to that, after the 4 years of OBGYN training, we specialize in another 2 to 4, now most commonly 3, of surgical, advanced surgical approaches, both laparoscopically with small incisions and the big open incisions, to attain the goal of ovarian cancer surgery, and that is to remove what we call an optimal debulking. Most ovarian cancer, as we talked about, is identified with disease outside the ovary and the upper abdomen, and the surgical techniques to correct that are broad, and people who are trained in it can attain that goal far more highly than general surgeons and OBGYN surgeons who haven't been trained in those techniques.
You've been there for 16 years.
I've been at LVHN for 16 years and I'm board certified for 20.
Okay, now, when I was in Mike's office, we were talking about the advances, the new advances that are happening today versus 16 years ago. And we're talking about different chemotherapies, Mike. We talked about different things. And the fact that, so you've seen in the 16 years, hopefully, some great advances in treatments of ovarian cancer.
Yeah.
Could you share something?
Well, I can tell you, when I first went into the specialty, the average life expectancy was 18 months. And then I kind of shake my head and I said, why did I even do this? It was so challenging. And those patients were in the hospital getting the majority of their chemo. They were sick, and they had the most amazing courage you can imagine of any group possible. They just put one foot in front of the other and kept moving. They were amazing. I think that's what drew me to them as a specialty. Now the average life expectancy with appropriate surgery and chemotherapy is over 6 years, so it's quadrupled in that time. And the cure rate is as high as 40% on those. So we do far better. And again, that data is now based on what we've seen over the past 5 years. What's going to come in the next 10 years is going to completely change that and can keep growing on that as well. So yeah, we're at a crossroads. We've done okay so far, but we're at a crossroads to do far better.
It's very encouraging to see what's out there. Okay, folks, I'm talking to Drs. Boulay and Dr. Evans. And Dr. Evans is in Hazleton Mountaintop. His number is 570-5014 LVH, and Dr. Boulay is 610-402-CARE. We come back and show you a clip that Dr. Boulay put together. We want to give you some more information. Remember, it's a simple thing, folks. You're looking at the biggest baby in the state of Pennsylvania. I go once a year, blood work, test, etc. And if you're experiencing anything, I highly, highly recommend that you get to a gynecologist and get checks. We'd like to see you around watching the Sam Lesante Show. We'll be back right after this. Welcome back to the Sam Lesante Show, folks. Remember, 24/7, SSP TV. You can watch all of our health shows. My guests today, Drs. Boulay and Dr. Evans, were talking about ovarian cancer. If you just tune in, folks, you know I play the Sam Lesante Show many times. Highly recommend. Go to our website. Call your friends. You can see this worldwide. Hopefully, we can save some lives. Dr. Boulay, you put together a documentary, right? Okay, so I want to show this 30-second clip, but tell our audience what they're going to be looking at.
Sure. Over the as we described, ovarian cancer in its over the past 20 years has increased in longevity fourfold. And I, as a specialist, see them for their chemotherapy and for their surgery. So I get to know these patients quite well. And I was amazed at their general look at their survivorship and what it meant, the changes in their lives. And this is information that's not regularly shared. So I worked with PBS 39, WLVTV, down in Bethlehem, Pennsylvania, and we put together a half-hour documentary that will air on their station in September 20th. And it's called Close to Home, and it's simply narratives of patients who've been through this, patients and doctors who've been through these experiences.
Well, let's show a clip of that, Sammy.
A cancer diagnosis does not have the same meaning as it once did.
This experience makes my home very dear to me. It makes me appreciate things in life, things that I had taken for granted.
People were so wonderful to us. They were there for us.
That's an incredible gift, to know that you're not walking alone.
We're all here to make each other's lives richer and happier. And cancer diagnosis is just part of the story.
That's just a part of that documentary, and you know, attitude, faith, prayer, hope is something that people begin to really emphasize. I had Dr. on the phone, Dr. I can't think of his name offhand, but he was talking about how important prayer is in healing process. Risk factors, Dr. Evans. Is there anything women could do to prevent, I mean, like, for example, lessen their risk?
For ovarian cancer, I would defer to what you would have to say, but
yeah, and you pointed them out earlier. So so most ovarian cancer we think is related to how many times that the body ovulates, how many times the ovary produces an egg. So if you can reduce those risks, or if you can reduce those numbers, you reduce the risks. And the way people do that is pregnancy, especially before age 30, being on birth control pills, specifically the hormonal ones, and breastfeeding after childbearing. Other ways that we talked about are reducing risk are surgical, removing the ovaries and tubes. And interestingly, over the past couple of years, I've completely changed some of my surgical approaches because we found that maybe as much as 40% of what we call ovarian cancer actually begins in the fallopian tube. So we can remove the fallopian tube and reduce risk by potentially as much as 40% and still maintain some ovarian function. So on many patients who choose to keep their ovaries, I will remove their fallopian tubes at the time of other surgeries, again, to reduce what we call ovarian cancer risk.
It's amazing. Here again, the medicine, the advances, the technology to sustain life. How about smoking? Does that have an effect on?
Not that we know of.
When I see young kids, young women smoking, it just tears me apart. I'm sure you could write a book on that, Evans.
Oh, absolutely. I mean, it just increases your risk of so many bad things, namely lung cancer, head and neck cancer, and even after the diagnosis, some of my patients drive me crazy because they continue to smoke.
Doesn't that something? Folks, I was going to have Dr. Boulay sing an opera song because he's an opera buff, but I figured we'd pay more attention over in cancer, and Tammy's here, and she says stick to the program. But it's interesting that you are in, you like opera and you sing then, right? Isn't that?
Yeah, I've actually recorded 3 CDs for cancer survivorship, and as part of this PBS documentary, we co-wrote 10 new songs.
Is that right?
That are all focused on topics of survivorship, and I'm recording them in
Mike,
next month.
We're with a star here. We're with a star. Not only is he a star in oncology, gynecology, but he's also a singer, an opera singer.
Everyone needs a day job.
Well, Doctor, it's nice meeting you, and I wish you the best, and keep up the good work. I can't say enough for Lehigh Valley Health Network. They just do a great job. And Dr. Evans, make sure you take good care of me. Okay,
Will
because
do.
I'm going to stick around here for a while. Okay. We could get Dr. Evans in the Hazleton and Mountaintop 570 401 LVH 4LVH, and Dr. Boulay at 610 402 CARE. We'll see you next time.